So good evening everyone. If I'm visible and audible, please give me a thumbs up guys so that I can see the chat and then we can start with the session. All right. So good evening. I got some messages from Dr. Nayak Jr. Okay. Am I visible and audible properly? Good evening guys. Okay. So let's not waste any time and let's start with the session without wasting any more time. Okay. There we go. All right. I'm properly visible and audible? Yeah. Sure. So let's start. So what I'll do is there are these previous year's INICET question. Welcome to this session, guys. This is the INICET previous year's question PYQ topics from anesthesia. We're going to cover that. And good evening to everyone. I prefer that we'll be discussing these questions out, and I just wanted if we can have an interactive session that will be much better. Otherwise, we'll just discuss all the points and we'll try to revise all the points from anesthesia in as much short time as possible. So let's start with the first question. I've shared my Instagram ID also. Any questions and doubts, you can ask me directly and contact me on Instagram. I'll be sharing the PDF as well. So let's start with the first question. Now, identify the equipment given below. As I said, I want it as an interactive session, so you guys can type the answer, and we'll just see as to how many of you are getting things right. And I think anesthesia questions are normally easy; it won't be a problem. And then we'll continue with the discussion beyond that. All right. So yes, guys. The answer to this question. So identify the equipment used below. There's an image provided, and you can see the options as nasal cannula, non-invasive ventilation, high flow nasal cannula, and continuous positive airway pressure. Dr. Nayak Jr. says C. Absolutely correct. So here what we are discussing are the oxygen delivery devices. Dr. Ayush and Dr. Sainath, everyone has said C. Absolutely correct. How did you identify? That's the point. You identified it by the presence of a humidifier. What you can see over here is a humidifier, right? No doubt this is a nasal cannula. So because there's a presence of a nasal cannula, you can also think of it as a normal nasal cannula which is there. But this is not a nasal cannula. Dr. John says, in INICET PYQ, what is that, sir? And how does anesthesia working in the surgery? Dr. John Bathula, we are discussing INICET, which is the AIIMS question paper. So any questions and doubts, you can ask me later. Let me finish off with the questions. So here I'm discussing which is the high flow nasal cannula. As I said, you identified it by the presence of a humidifier. This thing present over here, humidifier, makes you ensure that this device that you've got is a high flow nasal cannula. So when we speak of oxygen delivery devices, just to revise them in short, all the oxygen delivery devices, they are classified into two types. Generally, what we say here are the low flow devices and the high flow devices. All right. So the low flow devices, all of you would be aware, is the basic nasal prongs, which looks like this only. This is a normal nasal prongs, but it does not have a humidifier attached to the flow meter. What you see over here is the flow meter. When you've gone to the wards and you've started oxygen on a patient, this is the flow meter. All right. So here what you have seen is a humidifier. The presence of humidifier is characteristic to it. All right. Now, low flow nasal prongs, all right, or nasal cannula. After that, we get simple face mask. You have a partial rebreathing mask, and we also have a non-rebreathing mask. What we need to know is that what is the maximum FiO2 being delivered from each of these devices. So the maximum FiO2 that you can give through a nasal prongs is 44%, 44 to 45%. From a simple face mask is around 60%, partial rebreathing mask 70%, and non-rebreathing mask 90%. So remember, non-rebreathing mask, this provides the maximum FiO2 out of all the low flow devices. Okay. Now, high flow. When we speak of high flow devices, guys, here you have this device which you just saw. high flow nasal cannula. Remember, this can give up to 100% oxygen maximum. This is the maximum FiO2 being delivered, maximum oxygen that is delivered. All right. And apart from high flow nasal cannula, you also have Venturi mask. All right. And Venturi mask, the only point is that it delivers around 60% maximum. Though it is a high flow device, remember Venturi mask delivers only 60% maximum. It does not deliver more than 60. So if you will find in terms of FiO2, remember non-rebreathing mask delivers more than Venturi mask. Okay, in terms of percentage. Then what is the use of a Venturi mask? So remember, Venturi mask is more important when you need to give titrated oxygen to a patient. All right, titrated. Whenever we want to give titrated oxygen to a patient or controlled oxygen to a patient, like COPD patients. All right. This is where we use Venturi mask. Otherwise, we don't have so much use of Venturi mask. This is the reason behind it. Now, another thing, why is it called low flow and high flow? Remember, in the low flow devices, normally the flow rate in the flow meter, this is the flow meter. All of you must have seen in the wards, the maximum limit given here is 15. All right. So therefore, low flow devices work at less than 15 liters per minute. All right. So when you start oxygen to a patient, you normally start with 2 liters. You may start with 5 liters. You may start with 10 liters. But maximum that you give is around 15. All right. So therefore, the low flow devices, they work at the flow rate of the flow meter. That is the flow rate. Flow rate of less than 15 liters per minute. Normally, high flow devices, they have flow rate more than 15 liters per minute. Also, and the next part is that in case if it is less than 15 liters per minute, they have a special mechanism to make it high flow, like the Venturi mask. So we'll not go into too much details of that because it is based on the Venturi principle. All of you must have studied, but this I think covers up the topic oxygen delivery devices. All the points here are important regarding non-rebreathing mask, nasal prongs, simple face mask, and high flow nasal cannula, including Venturi also. Thumbs up, guys. All okay? Let's go to the next question. So this is an important topic, oxygen delivery devices. For any exam, it's very important. A 45-year-old male is found unconscious on the road. A thorough assessment reveals that the patient has a cardiac arrest. If you handle such a patient at the event site there itself, which of the following would be the first step in managing such a patient, right? According to ACLS guidelines. So the first option is check for carotid pulse, CPR, call for help and shock if available. Second is call for help, check pulse and do CPR. Third is observe. And fourth is just CPR. Yes, anyone? The answer? Yes, guys. What would you go for? A, B, C or D? Check pulse, CPR, call for help and shock. Do you think that's the answer? Correct. I got an answer from Dr. Nayak Jr. Dr. Nayak Jr. Jr. Whatever. Right. B is the correct answer. So when you are saying, so here the first thing mentioned here is call for help, check for pulse and do CPR. This is from all the options available to us. Now the point is why A is not the correct answer. All right. So here the point is patient already has a cardiac arrest. All right. So you have found the patient unconscious. Always remember this was last year's question. A is not the right answer. Dr. Sainath and Dr. Ayush. A is not the answer. Let me tell you why. See, call for help does not come at the third number. Call for help should come before you check the pulse. That's the reason. So when you're talking about the steps of CPR, absolutely in short, if I have to discuss, I'll be saying the first step is always scene safety. And also remember, before scene safety, in case there was a last year question on INICET triage. Remember, in a triage, the first person that you will first, when you see who to first resuscitate, in a triage, always remember it's an unconscious patient who goes for the first, you have to make for this patient. In a triage, unconscious patient is to be attended first. He is to be attended first in a triage. Okay. Unconscious patient is attended first. All right. Now, once you attend this unconscious patient, as you can see, being unconscious, this is the first person that you will attend, right, in the triage. After that, the next step, that is, once you start your CPR, the first thing that you do is scene safety. Safe for the victim, safe for the rescuer, and safe for everyone around. Take standard precautions. This is the first step. After seeing safety, the next step is check for response. You check for the response of the patient, if the patient is responding or not. If the patient is responding, leave the patient. If the patient is not responding, then the next step becomes important, which is not check pulse and breath. The third step is call for help. The only thing that you check on the patient is response, and if the patient is not responding, the next step is call for help. After you call someone for help, next is when you will check for breath and pulse. Remember, you're going to check the breath, and remember, you're going to check the pulse. Both are supposed to be checked within 10 seconds simultaneously. Now, you may get 4 options. So these are the first 4 steps. First step, second step, third step, fourth step, right? This is the order. When you check for breath and pulse, I may get 3 scenarios, right? It's possible for me to get 3 scenarios. The first scenario is that breath present, pulse present. When both are present, you keep the patient in the recovery position. Again, this question has been asked in exam. When breath is absent and pulse is present, what is missing is breath. In this patient, give breaths. Whenever you give breaths, remember it is always 10 to 12 breaths per minute. It depends on you, mouth to mouth breathing, mouth to nose breathing, mouth to mask, bag mask, whatever you want to do. If both are absent, pulse absent, breath absent, it brings me to step number 5. This is where you start CPR. So now if you will check the options from what we got, call for help, then came check pulse, all right, this part, and do the CPR. So this forms the correct answer, right? Call for help in point number A should have been first. So A is not the correct answer, B is the correct answer. Now, when you start CPR, remember you're supposed to do cycles of 30:2. Normally you complete them in 2 minutes, right? In about 2 minutes, and then check for pulse and repeat the whole thing again and again. And step number 6 is if AED arrives, defibrillator, then you use to check the rhythm. And in case the rhythm is ventricular tachycardia or ventricular fibrillation, these are the rhythms where you give a shock. All right, done. So this is absolutely in short the 6 steps which are there. All right. So the first step is seeing safety. Second is check for response. Third is call for help. Fourth is check breath and pulse. Fifth, in case breath and pulse both are absent, you start CPR. And remember that is chest compression, airway and breathing now, CAB. And the 6th step is in case you get the, remember you called someone for help. That person that you called for help is the one who's getting the AED. That's why you called him for help. All right. So now when you get the AED, you can check for the rhythm because the dying rhythms of the heart are ventricular tachycardia and ventricular fibrillation. And then you can give a shock over there. Thumbs up, everyone. Okay. Next question. Thumbs up. All okay? Dr. Shivani Gautam says, plus sir, please sing song at the end of the session. Oh, yeah, I'd love to. But you know, with the YouTube, what happens is that the noise gets suppressed. So my guitar doesn't get picked up now. With the new settings which are there on the YouTube, we have to have a special settings for the guitar and the instrument to pick up. I have the guitar here itself with me, but it's very difficult here. Nowadays, it's not getting picked up on the YouTube. If you see my old videos, they all have guitar in that. Okay. So sorry for that. Otherwise, I would love to. Okay. Anyways, let's come to the third question. A 15-year-old boy presented to the emergency department. A common question that keeps on coming in INICET based on the same thing. Emergency department with difficulty in breathing after being stung by a bee. All right. The lung wheezes are there. The lips are swollen. BP is 80/55 and epinephrine, adrenaline. Remember, epinephrine is adrenaline. That is injected as a part of the management protocol. Correct. What is the correct route and concentration? Dr. Samad says A. Dr. Shivani Gautam says for how much time you have to give CPR? Good question, good point. I'll just finish off that part also because it's a part of this. Remember, you have to give CPR for ideally 30 to 40 minutes. So all the students who are there as interns and post-interns, if you worked in the wards, you must have seen that when you are filling death notes of a patient, you write down the CPR over a period of 30 to 40 minutes because they say 30 to 40 minutes is a good time to give adequate CPR before you declare the patient dead. So 30 to 40 minutes is the time that you do CPR, or till the time patient revives. No, not till the time, means 30 to 40 minutes is when you stop the CPR, or if the patient is revived. And the third is in case you get advanced life support team coming, you will leave it. Let the advanced life support team take over and then they will handle the CPR. Okay. So whenever there are 3 points when you stop the CPR yourself, that is 30 to 40 minutes. patient is revived, and the third is when the advanced life support team comes. Okay, so that was the important point. So sorry guys, I had to go back because I wanted to clear that doubt of Dr. Shivani. Next is answer by Dr. Shivani, Dr. Nayak, and Dr. Samad. Correct. Intramuscular injection is what we were discussing. No, adrenaline was what we were discussing. Here, this is anaphylaxis. So remember, the correct route and concentration of ADR is the question. Now, again, this question keeps on coming as match the columns in INICET, or individually they can ask you about ADR. Absolutely correct. Intramuscular 1:1000 is what is used in anaphylaxis. Okay. Intravenous 1:10,000 is used during CPR. All right. So when we had discussed these CPR rhythms, remember one rhythm is ventricular tachycardia, ventricular fibrillation. I told you these are the dying rhythms. The other non-shockable rhythms where you don't give a shock. The non-shockable rhythms are pulseless electrical activity and asystole. And remember guys, here the drug that you use is ADR, adrenaline or epinephrine. And here what you will do normally is used 1:10,000 concentration. Okay. All right. And epidural 1:2 lakh. This is the most common used for local anesthesia concentration. Okay. So these are the various concentrations which are used. All right. Remember, normally adrenaline comes in a 1 ml vial, and that 1 ml is 1 milligram or 1:1000. Normally, when adrenaline comes, when you get adrenaline in the wards, what we have, all of us have used. Okay, so adrenaline normally comes in a 1 ml vial. That 1 ml is 1 milligram or 1:1000. Okay, that's about this one, ADR. Okay, so ADR is an important topic. Don't forget it. Please read this. Blue pipeline in the OT is for which anesthetic gas? Easy. Oxygen, nitrous, air, or vacuum? All of you would be knowing it, and I know all of you will give a correct answer to this. I'm pretty sure. Yes. Pretty sure about it. Okay, oxygen, nitrous, air, or vacuum? Correct. As I said, I'm pretty sure everyone gave me a correct answer. All of you, correct. It's B, nitrous oxide. Remember when we speak of pipelines. So, in terms of pipelines, oxygen is always white in color. Nitrous is always Neela, blue in color. Air is always black in color. And the vacuum which you get for suctioning is always yellow in color. All right. Apart from that, you also would need to remember the cylinders. So this was about the pipelines, right? Apart from that, you also need to remember the cylinders. So when you speak of cylinders, remember oxygen is always black body with white shoulder, right? Nitrous anyways always remains blue. Air is going to be gray body with black and white shoulder. All right. Vacuum, we don't have a cylinder. It's not there. All right. Cylinder of carbon dioxide is there, which is gray in color. And one more cylinder that you need to know is Antonox, which is a combination of oxygen and nitrous. So you get blue body with blue and white shoulder, right? Apart from that, the pin index numbers are important. So when you speak of pin index numbers, everyone would know. We start with air 1,5, oxygen 2,5, nitrous 3,5, carbon dioxide 1,6 or 2,6 depending on the percentage of carbon dioxide present, and Antonox, the longest name, has the number 7. Okay, so anesthesia machine, guys, always remember, is divided into 3 parts. You divide the anesthesia machine into 3 parts. The first is a high pressure system. The cylinders are high pressure, so it cannot be given to the patient directly. And that is why you have something called as the intermediate pressure system, which gets converted to the low pressure, which becomes safe for the patient because cylinder pressures are very high. All right. So therefore, the cylinders and all its attachments are the parts of a high pressure system, right? Up to from where to where? From the cylinders to the pressure reducing valve, right? Now, this also is slightly on higher side, so you can't give it to the patient directly. So from the pressure reducing valve to those oxygen nitrous knobs that you've seen on the machine, knobs. All right, those knobs which are there. These knobs are also called flow control valves. From here to here is the intermediate pressure system. And remember, intermediate pressure system has 3 important things which can be asked in INICET. And that is presence of an oxygen flush valve. All right. Apart from that, pipelines are also a part of intermediate pressure system. Okay. So these 2 things you need to remember. Pipelines and oxygen flush are part of intermediate pressure system. And the low pressure system is beyond the knobs, all right, up to the outlet. Beyond the knobs, up to the outlet. And this would contain that flow meter assembly and the vaporizer. It contains that flow meter assembly and the vaporizer. We'll not go into too much details. My only point is just to tell you what are the parts of various and what's the various parts of the anesthesia machine, so that you just know what's a part of high pressure, intermediate and low pressure. And especially with oxygen flush and pipelines, you need to remember that these are part of intermediate pressure system. With oxygen flush, there's one question that they keep on asking, and that is, what is a side effect of using oxygen flush? So oxygen flush is something that is used in emergency when a patient seems to be hypoxic or not getting oxygen, where I can just press a button and a patient gets 35 liters of oxygen. Point is, at 60 pound per square inch, which is a little bit on higher side, the pressure, remember it's intermediate pressure, it's not safe. It's not safe as low pressure. So therefore the side effect would be barotrauma. This is an important question. Okay, so oxygen flush can produce barotrauma if you use it in emergency. All right, that's the only point. So here I've discussed about the anesthesia machine. We discussed the colors of the pipelines, the cylinders, the important pin index numbers, and the parts of the anesthesia machine, right? Based on the previous year's questions. Any questions and doubts you can ask me. Otherwise, I'll go forward. Next. Now, this was, I think, 2 years back question, PYQ of INICET. Arrange the following anesthetic agents based on their potency. So there are 4 of them that you need to arrange: nitrous, halothane, isoflurane, and methoxyflurane. Okay. So the first option is methoxyflurane, halothane, isoflurane, nitrous. Methoxyflurane, iso, halo, and then nitrous. Methoxyflurane, nitrous, halothane, iso, halothane, iso, nitrous, methoxyflurane. Simple. If you don't know this answer, you will not be able to get it correct anytime. Okay. I think Dr. Samad has given the answer, I think, right? Okay. Correct. The answer here is A. Dr. Shivani also gives the answer. Correct. A is the correct answer. Okay, so this is based on what? This is based on minimum alveolar concentration. Remember, minimum alveolar concentration tells you potency, and it is inversely proportional to potency. These are the properties of the inhalational anesthetic agents. Okay, inhalational anesthetic agents, the first thing important about them is minimum alveolar concentration, and it is inversely related to potency. So therefore, for this, we had remembered like this, methoxyflurane followed by halothane, isoflurane, all right, sevoflurane, all right, then is desflurane, nitrous oxide. These are 5-6 important that you need to know, where remember M for methoxyflurane and M for most potent. N for nitrous oxide, N for not potent or least potent. Okay, not potent or least potent. I think everyone has given a correct answer. Huh? Budding Medico, Dr. Tabish, Dr. Budding Medico, Dr. Everyone has given a correct answer A. So remember this sequence. This sequence you need to know. I never tell anyone remember the numbers, because numbers it's not easy to remember. You don't even need to know it. You guys don't need to know the numbers. But this sequence is important. You guys need to remember the sequence. Okay, methoxyflurane, halothane, isoflurane, sevoflurane, desflurane, and nitrous, from the most potent to the least potent. All right, and it is inversely related to potency. So this is inhalational anesthetic agents, minimum alveolar concentration based on that. Apart from that, another important question which is here is regarding the next point. So when you're giving anesthetic agents from the inhalational route, inhalational matlab, even that is inhalational, na? Same thing, it works like that. All of you know, na? If you want to think inhalational by the mask, think inhalational like this. It's the same thing. Simple. So therefore, what would happen is that initially it starts from the anesthesia machine. It goes through the breathing circuits. From there, it reaches the alveoli. It goes to the bloodstream and ultimately reaches the brain. Remember, the action is going to be the brain. Even if you do this, where is the effect? Where do you get a kick? At the brain only, na? Whosoever says that I've gone outside and I just went, for a break. I've gone out for a break, whichever. What was the break for? For the lungs to feel good? No, it was for the brain to feel good. So action takes place at the brain. But is it going to the brain directly? No, it is first going into the alveoli, then goes to the bloodstream and finally reaches the brain. The inhalational anesthetics also work the same way. So therefore, in alveoli, the most important property is minimum alveolar concentration, which I just discussed, and this is inversely related to potency. When it goes to the bloodstream, the inhalational, just like oxygen, may get dissolved in the bloodstream. So that gets his Maharashtra is Delhi. Okay, that is also good, Dr. Samad. Fine. Anything else is good. Okay, you can remember it the way you want, the sequence. Then we speak about bloodstream. When it goes in the bloodstream, guys, remember here that concept is blood gas solubility, or it can be said as blood gas partition coefficient. Remember, this is also inversely proportional to onset and recovery. And the last, when it enters the brain, that concept of lipid solubility becomes important. So this is called as oil gas solubility in the brain, its entry, and this is directly proportional to potency. This thing you need to remember. Minimum alveolar concentration is inversely related to potency. Blood gas solubility is inversely related to onset and recovery, and oil gas solubility is directly related to potency. Depends on the three parts where the inhalational is going in the body. Okay, so alveoli, bloodstream, and brain, these are the three things. So the sequence of minimum alveolar concentration we have done. But for onset and recovery, we can use almost the same sequence we had, and we'll just change it slightly. Use the same sequence which was there. Maharashtra is Delhi. Agreed. We'll use the same thing as Dr. Samad says. And we'll change it slightly. Methoxyflurane, halothane, isoflurane. Alright. Sevoflurane. Till here it is same. Alright. Till here it is same. But after that, the only difference happens is now you get nitrous, you get desflurane and xenon. And this becomes from the slowest onset and recovery to here is the fastest onset and recovery. And you will find the values of nitrous and desflurane are similar. Don't go into too much details or remembering the numbers, that's not needed. But you can remember it like this. Okay. So we can use the same, I like the mnemonic that Dr. Samad has given. So Dr. Samad has remembered it like this. Maharashtra is Delhi. Right. We can use the same mnemonic. So here he has mentioned Maharashtra is Delhi. Am I right? So you can just change it the same way that he has remembered. Maharashtra. He has used M and H here, is here, and Delhi here, right? You can just change it as Maharashtra is not Delhi. You can just change it as Maharashtra MH is not Delhi. Clear? It's expensive. Alright. So we had a mnemonic here. Maharashtra is not Delhi. It is expensive. Clear? Now you can remember this also for the exam as one of the the way that you can remember this blood gas solubility or onset and recovery. So these 2 points are important over here that I wanted to discuss, and this was 2 years back question. Hopefully people have understood, and the mnemonic is also ready with us. Maharashtra is not Delhi, expensive. Okay, so here you have got a mnemonic as well. All right, so let me write here expensive. Done. Thumbs up, guys. Next question. Which of the following local anesthetics causes hypertension? Cocaine, lignocaine, bupivacaine, or prilocaine? So, which is the only one? So, there's only one which can cause hypertension, and that answer is which one, guys? What's the answer? Anyone? Correct. Cocaine. Absolutely correct. Cocaine. Remember, mostly all the local anesthetics, all, most in fact, all local anesthetics, right? Local anesthetics, they are vasodilators, except for cocaine. All anesthetics, local anesthetics are vasodilators except for cocaine, which is a vasoconstrictor. You can remember this vasoconstrictor, CO, and there is a CO here also. Vasoconstrictor. Can you see? CO and CO. All right. So cocaine is a vasoconstrictor. It causes tremendous vasoconstriction, and because of being a vasoconstrictor, it causes hypertension. Because all others are actually causing, all the others that you see over here, they are going to cause vasodilation. In fact, all of them cause vasodilation, and therefore they decrease the effect of local anesthetic drugs, and therefore we add ADR. That is why all of you must have seen that vial of lignocaine plus ADR, because lignocaine plus ADR becomes a better drug than lignocaine, right? But only place that you will not add ADR is cocaine. Remember, cocaine is contraindicated with lignocaine. Sorry, adrenaline. Cocaine is contraindicated with adrenaline. That's an MCQ question again. Okay. So all the others are vasodilators. They cause vasodilation. So they decrease the effect of local anesthesia drugs. All right. And therefore we add adrenaline, or even phenylephrine can be added. Phenylephrine is a better drug in fact. All right. So lignocaine ADR is a better drug. And in fact, better than ADR is going to be phenylephrine. If you compare the lignocaine versus lignocaine plus ADR, lignocaine plus ADR is a better drug. Then why don't we use it? Because of the problem, contraindication. So remember, this is contraindicated in the end arteries: finger, toes, ear, nose, penis. Finger, toes, ear, nose, and penis. So therefore, you don't know when to use and when not to use. It has contraindications, and that is why we don't use it so often. They're contraindicated in the end arteries. Okay, so next question. Which of the following is required for a cannulation of a newborn? See, there's other questions which come. All of you must have done this in the practical part as well. But such questions come in the exam also, including INICET. Simple. You're talking about a newborn. Newborn means someone who is just being born. So, will you use a 22 gauge needle? Remember, 22 gauge needle is the blue color. IV Cannula. Sorry, blue color. Right. 24 is the yellow colored one. So if you remember in pediatrics, when you went to NICU, NICU, or you just had a baby just received, did you use a yellow or a blue one? All of you have used a yellow one. Do you use a syringe? Yes, so that blood doesn't get clotted. Do you use a tape to fix it? Yes. Do you use normal saline? Yes, to flush it. But you are not going to use a 22 gauge for a newborn. Yes, this can be used for a pediatric patient. It can be used for a child. I agree. But the yellow one, which is used for the neonates, or in fact for preterm, we use the purple. The purple is 26 gauge. All right. So here the answer becomes 2, 3, 4, and 5. So as mentioned, Dr. Bading Medico, Dr. Tabish, everyone, Dr. Sainath, everyone has said correct. Dr. Ashutosh, all of you are correct. C. Okay, simple question. But since we have discussed two colors, why not discuss the other colors? Always remember. Okay, so we start with 14, 16, 18, 20, 22, 24, 26, right? Oh, great God, please bless your pupils. Oh, orange, great, gray, God, green, please, pink, bless, blue, your, yellow, pupils, purple. That's how you can remember 14, 16, 18, 20, 24, 26. These are the colors. And the most common used for adult is the pink one. These are used for blood and fluid resuscitation. And these are normally used in children and pediatric. Even 22 can be used for adults also. I'm not denying. Whose veins are not visible and not good, we can use that. But yellow and purple we already discussed. Okay, so this is about the various IV cannula. Okay. Sometimes they ask you the flow rate also. So remember, anything close to 50 is for the pink one. Around 25 is for the yellow one. Around 30. So it's for the blue one. So you can remember it as 10, 20, 30, 50. Around 10, around 20, around 30, around 50, around 100, around 200, around 300. This is ml per minute. Flow rate ml per minute. Okay. So this is how you can remember the numbers also. What is the flow rate in ml per minute with IV cannula? So I'm not saying these are exact numbers. Actually, books have mentioned this is 54, this is 92, this is actually 187, and this is 284, something like that. But you can't remember these numbers. So we have taken out 10, 20, 30, 50, 100, 200, and 300. Hopefully this gets done. Next, identify the incorrect statement in rapid sequence intubation. Okay, which is the incorrect one? Yes. Identify the incorrect statement in rapid sequence intubation. So pre-oxygenation with 100% oxygen for 3 minutes is done. Dr. Budding Medico says, oh great God, please bless your pupils. Remember that, huh? It's an easy way. I think most of you would be remembering it that way. A lot of people have different ways to remember, but this is a good one. Oh great God, please bless your pupils. Okay. Identify the incorrect statement in the rapid sequence intubation. So pre-oxygenation with 100% oxygen is for 3 minutes is done. High volume, low pressure cuff. It's the method of choice in cardiac arrest, and the induction agent and muscle relaxant are given simultaneously. Yes, all of you have given correct answer. I will go. Now this question was asked in the exam, and there was a confusion among the anesthesia educators also. They said that it could be C or it could be D. But from whatever I read and from whatever I know, I'm not saying others are wrong. They may have the different sources. From whatever I read, the answer is C. It's not the method of choice in a cardiac arrest patient. In a cardiac arrest patient, when someone comes to you, you do not ask the patient, if the patient, has just had food or not. What if a patient has just come with an accident? How do you come to know? So are you going to do a rapid sequence intubation there? No. Normally, this would be a rapid sequence induction, which is done in a full stomach patient. So I would rather want to put it this way: in a full stomach patient planned for emergency surgery. Planned for emergency surgery, not for emergency resuscitation. Someone who's dying, you are not waiting for that person, now let's save this person and first prevent aspiration. That you will take care later. To prevent aspiration, I'll just intubate the patient. So therefore, I'll not do a rapid sequence induction and wait so much for that. So according to me, cardiac arrest is the answer, which I will not mark. This will be second. So pre-oxygenation, is it done for 3 minutes? Yes, it is done in rapid sequence induction. Do you use a high volume, low pressure cuff? Yes, because this is what prevents the aspiration. The whole point is it's a full stomach patient where I want to prevent aspiration. Is it the method of choice in cardiac arrest patient? No, I don't think so. And this point, the induction agent and the muscle laxant are given simultaneously. Rather than using the word simultaneously, I'll say that simultaneously has not been a correct word. You can write it consecutively. Consecutive. Consecutive means you give induction agent plus immediately you give muscle relaxant. That is the meaning of consecutive, not simultaneous, but I'll say consecutive. So that word simultaneous was the problem for which a lot of anesthesia educators had even said that, it's not the correct answer. So I'm not saying they're wrong, but if these were the words that students could recall, because we don't know exactly if this came or not. This is what the students had recalled. Okay. So according to me, simultaneously would not be the correct word. A proper word would have been consecutive. We have given induction agent. Remember, the drug of choice is ketamine, but people are using propofol also. The muscle laxant of choice for rapid sequence induction is succinylcholine. Remember, it is the fastest acting. If not succinylcholine, I can also use rocuronium, the next fastest acting, and they are given one after the other. So they are given consecutive. Okay, so that's the point. So this is rapid sequence induction where you are going to give a cricoid pressure. So what is done here is Silix maneuver or cricoid pressure. So cricoid pressure means normally if this is the trachea of the patient, all right, this is the trachea. Here is the esophagus, which is connected to the stomach. Now someone's stomach is full stomach. The problem with this patient is there can be aspiration, there have been regurgitation and aspiration inside the trachea. So what we do in rapid sequence induction is that we are compressing upon the trachea. This trachea has only one complete ring, which is the cricoid. Rest all are half rings, if you know. So when you compress the cricoid, it abuts against the esophagus at the back. So esophagus being here, it will abut against the esophagus, and in that case, by chance, whatever regurgitation is coming out, because of the pressure at the cricoid, the esophagus gets shut off. Okay, so this is what is called cricoid pressure. So what we do in here is we do Silic maneuver or cricoid pressure of 30 Newton, and this basically shuts off the esophagus. Remember, no bag mask ventilation. All right. Here, the point is that you want to use these fast acting drugs because you are doing pre-oxidation, everything. All this is done because remember here, no bag mask ventilation. We are talking of a full stomach patient. No bag mask ventilation is to be done. Okay. So this is about that. Next. Which of the following is incorrect about high quality or quality CPR? Okay, simple question. Rate of compression 100 to 120 per minute. Respiratory rate is 20 to 25. Depth of chest compression in adult is 5 to 6 and allow adequate chest recoil. This question has been asked multiple times, many times in different ways. Okay, so rate of compression 100 to 120, respiratory rate 20 to 25, depth is around 5 to 6 and allow adequate chest recoil. Okay, correct. All of you have given me correct answer. Everyone, very nice, perfect. Okay, very nice. Respiratory rate is not 20 to 25. If you go back today itself we have discussed when we went, where were we? If you will, today itself, see, whenever you're giving breaths to someone, we are always giving 10 to 12 breaths per minute. All right, wherever you're giving breaths, you're always giving 10 to 12 breaths per minute. So simple, that 20 to 24 was the wrong point over there. Okay, so that's not correct. 20 to 25 is not the correct answer. Rate of chest compression 100 to 120, yes, this is wrong. So here the answer is going to be 10 to 12 breaths per minute. That is okay. Chest compression 5 to 6 centimeters. You can also write 2 to 2.4 inches and allow chest recoil. So all these are correct. All these are correct. All this is correct. Okay. So the incorrect answer was respiratory rate 20 to 25. Okay. Everyone is given a correct answer. Next one. Difficult. In case you get a question like this, and if you don't understand, leave it. Okay. This is one question, because this is ventilator. Ideally, many times it's not very easy to attempt ventilator questions. Okay, because many times even the doctors get confused. Even we can get confused, all of us, though we've been working for so many years now. But yes, we can. When it comes in the exam, all of us also can get confused. But let's see and try to answer this question in the best possible manner. Now, how to approach such a question which has ventilator settings along with an ABG? Normally, identification of an ABG is all difficult. Okay, identification of an ABG problem is difficult. Upon that, they're asking in the exam, change the ventilator setting based on ABG. No, so much anesthesia you don't need to know, or ICU. Okay, but still we will tackle the question and I'll try to help you in the best possible way that I know. Acute pancreatitis patient, we are expecting ARDS, right? Maybe intubated on the ventilator, or even if you're not expecting ARDS, let's take it away. Patient is intubated and on ventilator. The settings are tidal volume of 420 ml, a respiratory rate of 32, PEEP of 12 centimeter, and FiO2 of 0.9. Okay, 0.9 FiO2 would mean 90% FiO2. Remember, maximum is 100%. Okay, maximum is 100%. So patient is already on 90%. The PEEP is 12. Respiratory rate is 32. Our normal respiratory rate is around 12 to 16. At the max, we can take it as 20. This is the normal. Here the tidal volume given is 420. A normal tidal volume, what we study in physiology, is 8 to 10 ml per kg, which for a 50 kg person would be around 500 ml. Right? 60, 70, it will be different. But you have to remember, nowadays in ARDS especially, or ventilator, there is something called as lung protective strategy, which was a question this time in NEET PG. The lung protective strategy says that you are supposed to give a low tidal volume and a high PEEP. A low tidal volume of 4 to 6 ml per kg and a high PEEP up to 20 can be given. These are the new settings which you can do, right? Look at the ABG and what is the problem in the ABG. So if you will ask me, the pH is 7.33, okay? So, which means normal pH is 7.35 to 7.45, slightly less. PCO2 is 48. Normal is around 35 to 45, right? PO2 is 110. Anything above 90 is supposed to be good. Bicarb of 28, to 24 to 26 is what we take bicarb. SPO2 of 100%. Okay. So even let's not understand about what has been asked. Let's look at what the options are given and what can it do for the patient. Now, the patient has SPO2 of 100%. If you decrease the FiO2, which was at 90%, if I decrease the FiO2 from 90, I'll make it 80. If I make it 80, this 100% and PO2 is 110. Normal PO2 should be more than 90. Does it make sense if I reduce the FiO2 from 90 to 80 or 80 to 70, the PO2 from 110, it will come down to 100. Maybe it will come to 95, but this is also normal. And saturation would remain 98, again normal. Now, let me look at the other option, which means this can be one correct option. This can be a correct option, according to me. Okay, this can be correct. If I increase the tidal volume, I am going to increase the oxygenation because the patient is going to breathe more. Do you want more oxygen? For someone whose SPO2 is 100%, do you want more oxygen? No, I will not want this. If you increase the tidal volume, I'm going to, sorry. Yes, one way I'm going to increase the oxygen, but at the same time looking at the CO2, if I increase the tidal volume, right, another thing that can happen is it can decrease the carbon dioxide of the patient. So do you want the CO2 to go down? CO2, little bit if it can. Okay, I don't mind, but I don't want the oxygen to increase. If I decrease the respiratory rate, RR, so if I decrease the respiratory rate from 32, the CO2 will increase, which I don't want. If I increase the PEEP to 14, it is going to further increase oxygen, which I don't want. Only two options are left. Okay, there is only two options left for me, which is I can decrease the FiO2 and I can increase the tidal volume. There are two options. Now you have to choose between these two options, right? Decreasing the FiO2 of the patient or increasing the tidal volume of the patient. So remember, whenever you tackle these questions of ABG, now if you have to increase oxygen based on the ABG, there are only three things you can do. Increase FiO2, increase the PEEP, or increase the inspiratory time of I/E ratio. The other thing is, if you have to decrease carbon dioxide, there are only two things you can do. One is increase the tidal volume, increase the respiratory rate, right? And other thing is increase the expiratory time of I/E ratio. Okay. If you want to decrease based on ABG. From the ABG that we have, right? So everything seems to be absolutely okay. There are two options which you can mark in the exam. If you will ask me, both the options are ideally correct, right? But if I have to choose only one out of them, so decrease FiO2 is correct according to me. Increasing the tidal volume is also correct according to me, because it's going to decrease the CO2 slightly and make the ABG normal. Okay, so these two are correct options according to me. But if I have to choose between the two, in that case, remember, both the options are correct according to me. If I have to choose according to me, I am going to choose decrease FiO2, Because oxygen so much is not needed in the patient. You don't want PO2 110. That is the only reason. If I had to target carbon dioxide, for me, increasing tidal volume would have been okay. But because the PO2 has been given as 110, which I don't want, had it been around 95, then I would have straight away given the answer as increased tidal volume. Okay? Dr. Tabish says B. Dr. Tabish, that's what I'm saying. Both the answers are correct, but if I have to choose, I'm going to choose option A because the PO2 has been given as 110. I don't want a PO2 of 110. 90, more than 90 sufficient, right? Remember, oxygen toxicity is also detrimental to the patient, right? So you have to choose between two poisons, two things. And out of the two things, what will I choose? I will choose the option A. Okay. As I said, these are PYQs. So none of us know if they have been the actual questions which have come in the exam, right? It's based on the recall of students. So there may be few things here and there, but at least it gives us a way to discuss the answers, right? That was the whole point about it. All of you, thumbs up. Did you understand? The main important point is, look at this. What will happen based on the ABG? Like, how do you change the ventilator settings based on ABG for the exam purposes? Like, if oxygen is more or CO2 has to be decreased based on ABG. That's what I've discussed. Okay. Remember, both the options are correct, A as well as B. They are not wrong. But if I have to choose, I am going to choose option A because I don't want a PO2 of 110, which is saturation of 100. All of you know that your saturation on pulse oximeter 98 is good enough. All of us know that anything above 95 is good enough. So I am going to initially come down of the FIQ. The first principle of ventilator is that, try to come down of oxygen as much as you can and as early as you can. You're not going to give 100% oxygen. So this 0.9% which has been given has to be decreased to 0.6 as early as possible. You're not going to give 90% to the patient always. I want to come down to 60% as early as I can. So even if the ABG is around 7.33 pH and PCO2 is 48, I'm okay with that. But I want to come down on oxygen for this patient. It can cause oxygen toxicity. Okay. Dr. Tabish says reducing the CO2 can be better at this point. Yes, and changing the setting again. But I understand the point. That's what I'm saying, Dr. Tabish. See, I'm not saying this is the correct question that has been framed and asked in the exam, but hopefully all of us have had a discussion. So the next time when you get the answer or a question like this, you know how to think about it. Okay. I'm not saying this is perfect. I'm not saying it's the correct thing. And I'm not even saying it's the correct answer. Right. But at least you people have a thought process where you can address this question in case if it comes in exam. How to think about it. As I said, the first thing I started was leave the question. But now I'm saying don't leave the question. Think about it. So at least I've given you the point how to go forward to thinking a question like this. Right. As I said, I may be wrong. Yes, it may be increased tidal volume because both the options are correct. I told you why C and D are wrong. C and D is not going to be there. Out of A and B, I've chosen my answer and I will go with A, but B is also not wrong. But at least you guys have understood how can we approach this question. Correct? Yes. Shall I go forward then? Good. This was a good discussion, right? All of you. That's how questions come in INICET. That's what we need to target, right? Okay. So, next question. A 15-year-old boy, easy question now. Sometimes from anesthesia you get such questions. Normally anesthesia questions are easy. But yes, sometimes you will get such ventilator questions which are difficult. Okay. Now, a 15-year-old boy reported to the emergency department with difficulty breathing. A monitor was attached and the following graph was seen on the capnography. What can be the diagnosis? Okay. So you've given a graph that you've got acute bronchial asthma, pericarditis, cardiac tamponade and bronchospasm. Simple. All you can see here is a shark fin appearance. In the graph that you see, you can see a shark fin appearance. And shark fin appearance can be bronchospasm, correct. But the same thing is asthma as well. So both A and D are correct. And the correct answer is option D, A and D, right? Shark fin appearance. So always remember when we speak about capnography, the graph would look something like this, okay? The normal graph. The normal capnography graph, it looks like this. Sort of, okay? So this part, the initial part that you've seen over here, this is basically going to be baseline and dead space. Dead space gas. Now, the upslope which you get to see, that's a dead space with alveolar gas. So this is alveolar gas plus the dead space gas. After that, we get a alveolar gas plateau, which is only carbon dioxide. And then when the graph goes down, it is inspiration. So always remember, these are the points of the graph. This is A to B, B to C, C to D, and D to E. So always remember, whenever the graph is sort of going up, it is expiration. A graph going down is inspiration. A graph going up is expiration. When the graph goes down, it is inspiration, because the capnography monitor can detect only carbon dioxide. All right. Okay. So here what you have seen is a shark fin appearance. All right. There are various other things. More questions are there, which we'll discuss later. But this is in general what you get to see. So a normal graph would look like this, but when it comes like this, it means there is some problem with the expiration. Some problem is there with the expiration. And what is the problem? You have got this because this is what is called as the shark fin appearance, which means there is an obstruction to the airflow. Obstruction to the airflow means bronchospasm. Okay. So therefore it can be bronchospasm or acute bronchial asthma. They are all correct. Okay. So next question. Which of the following test is depicted in the image? As you can see, simple question, but not in the exam. Okay, not in the exam. All right. So, which of the following test is depicted in the image? There's an image given to you: Allen test, Durkin test, Roos test, and Addison test. Since you are attending here in anesthesia, all of you would know and give me the correct answer. Allen test, absolutely correct. Okay, absolutely correct. Yes, I can see all the answers. Right. Correct, correct. But guys, remember, a lot of people can also think of this as the Durkin test. Durkin test, guys, remember, is for carpal tunnel syndrome. Am I right? Here is for thoracic outlet obstruction. All right. So therefore, this would look like Allen's test only. Okay, but here it is Allen's test, guys. So remember, in exam, it may be difficult, it may be different from what you're seeing it over here, because suddenly they might get confused. Allen's test, remember, is to check the patency of the collateral supply, and if it is positive, so basically less than 7 seconds, it should get filled up. That is being positive, right? A positive means it should get filled up in less than 7 seconds, and you can proceed ahead with the whatever procedure you want to do. The same thing that you study in surgery also. So this, what you can see over here, is Allen's test, which checks the patency of the radial and the ulnar collateral supply. Okay, so that's about this question. Next, this is what in anesthesia it's important for arterial line and ABG, for arterial line cannulation and for arterial blood gas sampling. So in anesthesia it's important for this. And remember, arterial line in anesthesia is used for a invasive blood pressure monitoring. Invasive blood pressure monitoring. Okay. Next question. Which of the following is a second generation laryngeal mask airway? LMA Procil, Ambu LMA, intubating LMA, or classic LMA? Okay. Again, I think all of you would give me a correct answer here. I'm pretty sure. Second generation laryngeal mask airway. Means not the first, the second generation. All right. So here, the correct answer is yes, guys. Dr. Tabish says thrombophlebitis. नहीं, thrombophlebitis किसमें Dr. Tabish? I didn't get your point. इसमें thrombophlebitis क्यों होएगा? हाँ, मतलब thrombophlebitis, inflammation of the veins would be there, na? That's called thrombophlebitis. Dr. Tabish says A. Correct. Absolutely correct. LMA Procil. Okay, remember all this Ambu LMA, intubating LMA, classic LMA, these are first generation LMA. So laryngeal mask airways are classified into two types. All right, the first generation and the second generation. All right, the first generation laryngeal mask airways, they have only one tube, which is the ventilating tube or the airway tube. The second generation LMAs have two tubes, right? Of course, one is the ventilating tube, but apart from that, they have also given a drain tube. Drain tube is for us to insert a Ryle's tube or a nasogastric tube, which is inserted inside the stomach, from where you can do a suction. And the biggest advantage is because I can suction the stomach. The biggest advantage I get because of this is that it can be used for IPPV in anesthesia, as it decreases the chances of aspiration. Remember, it does not prevent aspiration. It just decreases the chances of aspiration, because here there is a single tube that you get. This is used in anesthesia, the first generation LMA, only for spontaneous breathing patients. Short procedures. And comparatively higher chances of aspiration. Therefore, first generation is contraindicated for IPPV. Clear? Okay, so here's the point. Okay, so what are the first generation LMAs that we know? The first generation LMAs are the normal classic LMA, intubating LMA, all right. Then there is flexible LMA and unique LMA, and most of the AMBU LMAs. Second generation LMA, we have the ProSeal LMA, all right, Supreme LMA, iGel, and AMBU Aura Gain. This is the only one AMBU LMA, AMBU Aura Gain. Rest all AMBU LMAs are first generation. So here we have discussed the first generation and the second generation LMAs. Okay, so this is the difference between them. Next question, easy. All right, the 9-year-old boy required general anesthesia for inguinal hernia repair. Which amongst the following is the induction anesthesia of choice in this age group? 9-year-old boy is requiring a GA, right, general anesthesia for inguinal hernia repair. Which is the one that you will use? Everyone knows the answer. Correct. All right, so this ideally is the drug of choice for a pediatric patient. It can be used for a respiratory disorder, liver patients, non-hepatotoxic. All right, so pediatric patient, respiratory disorders because bronchodilator. It can be used for liver patient, also for CNS. I will prefer to use sevoflurane, right? And lots of books have mentioned even the decode. Desflurane, kidney patient, all right, in a patient of shock, old patients, right? This is where we use desflurane. Remember, desflurane is contraindicated in respiratory. In pediatric, it can cause bronchial irritation. In fact, it causes the maximum bronchial irritation. Correct. All of you have given me correct answer. Huh? All of I can see A from everyone. Correct. Okay. फिर आते हैं halothane. Halothane, yes, it can be used for pediatric patient and respiratory disorders. Yes, it can be used, but not preferred. Not preferred. It is not preferred. It has lots of problems. It can cause arrhythmias. It can cause hepatitis. Right, arrhythmias, hepatitis. It is known to cause shivering. A lot of shivering after the anesthesia part, right? So arrhythmias, hepatitis, shivering. All these are problems that you see with halothane. Okay. Isoflurane. This, according to me, is the best drug to be used for a CVS patient. All right, and for liver transplant, CVS patients, and for liver transplant. All right. Otherwise, most of the places now, the drug of choice is sevoflurane, because sevoflurane, liver patient, CNS patient, daycare, you can also use it for CVS. The only place where you would want to avoid sevoflurane is renal patient, kidney patient, and that is where desflurane is the drug of choice for kidney patient. So sevoflurane is avoided only in kidney patient. And if you want to use a single agent for both induction and intubation, single agent, again the answer is sevoflurane. Clear? So discuss in one part only all the drugs that are used for, all the inhalationals and where they are used and what are the major contraindications for each of them. Okay, so this we discussed all of them over here. Okay, next. Which of the following is not an ideal step for effective CPR in adults? Yes, 100 to 120, depth of compression 2 to 3, compression to ventilation ratio 30:2, allow complete chest recoil. Yes, guys, such questions keep on coming. 100 to 120 compressions per minute, depth of compression 2 to 3, okay, compression to ventilation ratio 30:2, and allow complete recoil in between the compressions. I will go with the answer B. Correct. Dr. Sainath says that. Dr. Sainath, correct. B. 100 to chest compression per minute. Is it correct? Yes. Depth of 2 to 3? No. We have just mentioned a while back 5 to 6 centimeter or 2 to 2.4 inches. Compression to ventilation ratio 30:2 everywhere. Except where? Except for a pediatric patient. Except for a pediatric patient with 2 rescuers where it becomes 15:2. All right. So this is also correct. And allow complete recoil. Yes, this is also correct. All of you have given me correct answer. Correct. All of you have given me correct answer. Next, a 45-year-old patient undergoing surgery was administered 85 milligram of rocuronium to induce anesthesia. Okay, rocuronium was being given 85, but the induction failed or difficult intubation. More than that, it has to be intubation failed. I'll rather put it this way. This wording may be wrong. It is intubation failed. Which drug should be administered for immediate reversal of rocuronium? Immediate reversal of rocuronium. Which drug? Correct? All of you? Yes, correct. Sugammadex. So remember, a normal reversal is used with neostigmine. But problem with neostigmine is that it has a ceiling effect. And you might have to wait before you use neostigmine. It is not going to cause a fast reversal. It may have a ceiling effect. Sometimes immediate reversal not possible with neostigmine. Immediate reversal sometimes not possible with neostigmine. That's exactly why Sugammadex is made, because it can cause a fast reversal. What does it do? Is basically it causes encapsulation. So if you speak about Sugammadex, it causes encapsulation and inactivation of rocuronium. For example, if this is rocuronium attached to the receptor, what Sugammadex will do is, if this is rock, it will encapsulate it like this. This is Sugammadex. It's like a binding agent or a chelating agent. So it will combine with rocuronium. It's going to form a complex, and this complex is then thrown away, discarded. So you don't need to give a reversal at all. It forms a complex. It's like a chelating agent or binding agent. It encapsulates, inactivates, and takes it away. Okay, so that's Sugammadex. Glycopyrrolate. Yes, it is given, but it does not use for reversal. Not for reversal. This is not for reversal. Correct. Edrophonium also, though it is anticholinesterase, not used. Though it is anticholinesterase, it is not used. Why? Short acting. Not used because edrophonium is short-acting anticholinesterase. Neostigmine, on the other hand, is intermediate acting. Intermediate acting. All right. So this is about the part. Also remember, there's another one called physostigmine, which is long-acting. So these are anticholinesterases. These are acetylcholinesterase inhibitors. So we've already seen about edrophonium, short acting, neostigmine, intermediate acting, pyridostigmine, long acting. So the short acting is not used, long acting is not used, intermediate acting, neostigmine is used. And there is physostigmine. This crosses the blood-brain barrier. It is not used. Okay, this again is an important point. Physostigmine crosses the blood-brain barrier. It is not used. Clear? Next, a neonate is brought to the pediatric ER, okay, with respiratory distress, cyanosis, and a decreased breath sounds on the affected side and presence of a scaphoid abdomen. Which of the following should not be performed? So you've got a child who is in respiratory distress, the baby has cyanosis, there is a decreased breath sound, and a scaphoid abdomen. So whenever you get to read this history, we are dealing with ideally congenital diaphragmatic hernia. Common question which keeps on getting asked. Remember, all of you already know it. Correct. Correct answer given. Right. Dr. Sainath. Okay, it's bag and mask ventilation. Will you perform a positive pressure ventilation? Yes. Oxygen therapy? Yes. Into intubation? Yes. In fact, had they mentioned OG, orogastric tube or NG tube, even that would be correct. But bag mask ventilation is contraindicated, right? So this is again a condition where it is contraindicated. There is high risk of aspiration. So all these conditions, with high risk of aspiration, bag mask ventilation is contraindicated. Okay. So high risk of aspiration means a full stomach patient, pregnancy, ascites, okay, tumors, abdominal tumor, right, hiatus hernia, intestinal obstruction, volvulus, or delayed gastric emptying, or congenital causes, congenital diaphragmatic hernia, tracheoesophageal fistula, meconium aspiration syndrome, pyloric stenosis. So all these are considered as risk of aspiration. Okay, clear? So here bag mask ventilation is contraindicated. All these conditions which are called as risk of aspiration, high chance of aspiration. Now, a 55-year-old male patient is undergoing laparoscopic cholecystectomy. During the surgery, there is a sudden decrease in the EtCO2. Similar question was asked in this time January FMGE. A sudden decrease in EtCO2. Remember, this is the point. Sudden decrease in EtCO2 to 7. The patient's SpO2 was 90 and the peak airway pressure was 16. All right. The patient became hypotensive. Which of the following is the most probable diagnosis? Pneumothorax, endobronchial intubation, CO2 embolism, or bronchospasm. They are talking about EtCO2. So there is a sudden drop of EtCO2, and when there is a sudden drop of EtCO2, the answer from the options given here is CO2 embolism. Carbon dioxide embolism. Patient, correct. Dr. Dheeraj, absolutely correct. Okay. Laparoscopic surgery, you are using carbon dioxide gas for insufflation. One of the commonest things that you're going to see is CO2 embolism. Remember, pneumothorax, the EtCO2 is going to look like this. Endobronchial intubation, it's gone in a bronchus, it may look like this. Bronchospasm, as a shark fin appearance which looks like an obstruction. So can you see, in obstruction all these things are happening. In CO2 embolism, if it was like this, suddenly there is zero. This is what is called as sudden drop to zero. Sudden drop to zero can be for 3-4 things. There can be esophageal intubation, your tube has gone in the esophagus, right? There can be embolism, right, where there is sudden drop to zero. Apart from that, there is no CO2 production, which is cardiac arrest. Cardiac arrest. Accidental extubation. So esophageal, let's put another one, extubation. Extubation of the patient, accidental. All right. Cardiac arrest and disconnection from the circuit. Disconnection from the circuit. All right, and cardiac arrest. And cardiac arrest. Okay, so this is what is seen in CO2 embolism. I mean, sorry, sudden drop of zero is seen in all these conditions. Now, another point is that you will find CO2 embolism means an embolus has gone in the heart. If this is the heart, so it goes, and this is how it's coming out, right? So embolus will go and block the heart like this. Embolus goes and blocks the heart. So neither the blood is coming here nor it is going forward. Because of this reason, the SpO2 also will start decreasing, right? And here the EtCO2 will also start decreasing. So in case of an embolism, you will find EtCO2 is suddenly trying to come down, will go down to zero. SpO2 also will start decreasing. But remember, in embolism, there is no problem with the respiration. So here the peak pressure remains normal as it has been given in the question. The airway peak pressure 16 is considered normal. Up to 20, I would still say normal. Up to 20, peak pressure of the respiratory system is normal. So you will find in pneumothorax, respiratory problem, peak pressure increases. Endobronchial intubation, respiratory problem, the peak pressure will increase. Okay. Another way to look at it, pneumothorax, you will find the peak pressure increases because pneumothorax is a respiratory problem. Endobronchial, this is a respiratory issue. Okay. Endobronchial intubation, your tube has gone in one bronchus. Again, the peak pressure increases. Bronchospasm is an obstruction. Again, the peak pressure will increase. Respiratory problem. Can you realize all the three are given as respiratory problem? Embolism is a cardiac problem. CO2 से कैसे embolism होगा सर? डॉक्टर आयुष. हाँ, वेरी गुड. डॉक्टर आयुष, होता क्या है ना, when you are using laparoscopy, तो laparoscopy में क्या करते हैं, स्टमक को इंसफ्लेट करते हैं. ठीक है, दिस इज द स्टमक ऑफ द पेशेंट. ये पेशेंट है, सॉरी, ये पेशेंट हु इज लाइंग डाउन, ही इज द पेशेंट लाइंग डाउन इन द ओटी. ऑलराइट. सो होता क्या है, यहाँ पे ब्लड वेसल जा रहा है, and when they use a Very's needle, so you don't know and you can't see inside when the very first time you are using that Very's needle of surgery. Remember that question comes in the exam, laparoscopy, Very's needle. इसका इमेज भी एग्जाम में पूछते हैं. ठीक है, तो जब ये Very's needle अंदर जाता है, तो as soon as it goes inside, they immediately insufflate carbon dioxide from here because they are expecting the carbon dioxide to get spread here in the abdomen like this, so that the stomach will become, you know, insufflated, and then they can start with laparoscopy. But in case the Very's needle is inside the bloodstream, the carbon dioxide enters here, and this has gone to the heart, leading to embolism. Is this clear? Very clear, Dr. Ayush. Thumbs up. Okay. हाँ या ना, होपफुली. ऑलराइट, देखो तो मुझे पूछ लेना फिर से. थोड़ा पानी पी लेते हैं, मेरे को जब तक आंसर आता है एक बार मैं देख लूं. ठीक है, डॉक्टर आयुष से ओके. ठीक है डॉक्टर आयुष, चलो. अरे मोस्ट वेलकम. आई फील वेरी गुड. Ask the questions here. If not us, you will ask whom? मेरे को तो इंस्टाग्राम पे इतने क्वेश्चन आते हैं रूटीनली वाले, पता है इंस्टाग्राम पे पीजी के समय कितने स्टूडेंट्स ने मुझे फोन किया, मतलब इंस्टाग्राम पे पूछा विच ब्रांच टू टेक, एनेस्थीसिया कैसी ब्रांच है. So many of them have picked up anesthesia, and the ones who have picked up anesthesia, the NEET PG one, they're so happy with that. Okay, the ones who have picked up by choice. Okay, the ones who picked up by choice. All right. So you can always connect with me. Don't worry about that. I've shared my Instagram ID. Now, next question: which of the following corresponds to ASA grade 3? Okay, which of the following corresponds to ASA grade 3? Moribund patient, patient having systemic illness which is under control or without any functional limitation, patient having systemic illness which is not under control, or patient having systemic illness which, remember एक एक करके जाते हैं. Moribund patient not expected to survive, this is ASA grade 5. A patient having systemic illness which is under control and without any limitation is ASA grade 2, because ASA grade 1 is a normal patient. ठीक है. ASA grade 3 is a systemic illness which is not under control. This becomes our ASA grade 3. Alright. And patient having systemic illness which is a threat to life, this becomes ASA grade 4. Clear? So this is your ASA grade 4. Here the question has been asked ASA grade 3, a patient having systemic illness which is not under control or with functional limitation, that is ASA grade 3. Correct. Answers by Dr. Dheeraj, Dr. SSR. Correct. All of you are correct. The ones who have answered. Next one. A 7-year-old child was being delivered oxygen by nasal cannula at 3 liters per minute. What is the percentage of FiO2 being delivered? Okay. So when you speak of a nasal cannula, a normal nasal cannula, there is a formula to calculate it, which is 21 plus flow rate multiplied by 4. Okay. 21 plus flow rate multiplied by 4. So this is 21 plus 3 liters per minute. 3 multiplied by 4. So 21 plus 12. How much it is? 33. So this is basically 33%. Now which is the closest answer to 33? It is 30. So we'll mark the answer as B. Okay. So this is a formula only for nasal prongs. Okay. For nasal cannula, nasal prongs, this is a formula for the FiO2. How much FiO2 is going? It is 21 plus flow rate multiplied by 4. Dr. Dheeraj is saying, is pregnant patient with controlled hypertension ASA grade 2 or ASA grade 3? Good question. Pregnant patient becomes ASA grade 2 as such. Okay. So remember, ASA grade 2 is pregnancy. Pregnancy is ASA grade 2. All right. So if anyone will say pregnant and ASA, and he's saying asked with controlled hypertension. So basically what happens is, I'll put it this way. You can think like this. If a patient has one or two system abnormality, consider the patient as ASA grade 2. If a patient has two system abnormality, consider as ASA grade 3. So if you will ask me a pregnant patient with controlled hypertension, I will take two of them, two systems to be involved. So I will take the patient as ASA grade 3, pregnancy with controlled hypertension. Okay, but yes, there can be debate here. People will say कि controlled hypertension तो क्या हुआ? That can also come as ASA grade 2. But no, I will prefer it as pregnancy with controlled hypertension as ASA grade 3. Okay. All right. So this is one thing that you can take, one system or two system abnormality. Just one system abnormality, ASA grade 2, and two system abnormality, ASA grade 3. Okay. As I said, there can be confusion on this also. These are all those confusing and bad questions. Right. So here the answer was B. Next question. Identify the steps of intubation sequence. Flexion of a lower cervical spine and extension of atlanto-occipital joint. Inflate the cup of endotracheal tube, introduce a laryngoscope and confirm the position. Correct? Identify the steps of intubation. So flexion of the lower cervical spine and extension of atlanto-occipital joint, which means neck flexion, and this is head extension. So they are giving it all correct. This is neck flexion, which is correct. Inflate the cup, this is also correct. Introduce the laryngoscope, it is correct. This is also correct. But you just have to identify. The first thing that you will do. Yes, anyone? Dr. SSR says, nice explanation. Okay, thank you. Hopefully you've understood here. Hopefully it's helpful for all of you. Hopefully. Thank you guys. Okay. So, answer D says Dr. SSR and Dr. Ayush. Correct है. Okay. The first thing you will do is remember laryngoscopy position. So when they are talking about this is basically the laryngoscopic position. So the first thing is you will put the patient in the position, right? After the position, the next step will be to introduce the laryngoscope from the right side of the mouth. After that, you have intubated the patient and then you will inflate the cuff and then you will confirm the position. So therefore, A, C, B and D correctly pointed by all of you. Correct. The answer is D. Absolutely correct. Okay. Now, glycopyrrolate is used as a pre-anesthetic agent for reducing the secretions, sedative effect, skeletal muscle laxant, or anxiolytic. Yes. Yes, guys. Simple, na? What is the answer? A. Dr. Sainath says correct. Reducing the secretions. Glycopyrrolate is used as a pre-anesthetic agent for reducing the secretions. Remember, yes, it is the drug of choice to reduce the secretion. Glycopyrrolate is considered in anesthesia as the drug of choice to reduce the secretions. Correct. All of you are correct here. Next question. Identify the equipment shown in the image below. What can you see? Is it a mechanical ventilator, infusion pump, CPAP machine, or nasal cannula? Simple question again. All, if you enlarge the image, all you can see here is this, which is going to give oxygen to the patient. From here oxygen will go, from here oxygen will go. This is nothing but the same answer D, nasal cannula. Okay, this is the nasal cannula which you see. It's the same image which we had seen before, you know, when we had seen before. The same image, it's the same thing which we are seeing over here, nasal cannula. Correct, the same thing which we had seen in the beginning. The two prongs which are going, they are going inside the patient like this. All right, they're going inside the patient over here. That's the nasal prongs that you were seeing. All right. Okay, so here the answer is nasal cannula. Correct. All of you are right. Dr. Dheeraj, Dr. Ayush, correct. Nasal cannula. Next question. These instruments are utilized for, again, this was asked in INICET. Okay, simple. What can you see? All of you already know it. You can see here a laryngoscope. So you are seeing a laryngoscope, but if you will realize there's no endotracheal tube given. Laryngoscope is seen. You can see a oropharyngeal airway. You can see a McGill forceps. You can see a stillet. You can see different types of laryngoscopic blade. You can see a tape and you can see a syringe. So what are you going to do? Handle the airway. Correct. All I'm going to do is central line, no. Umbilical catheter, no. Arterial line, no. My answer is airway management. Correct. Absolutely correct, all of you. C. Which of the following can be considered effective CPR? Respiratory rate 20 to 24 per minute. Chest compression 100 to 120. Allow complete chest recoil 5 to 6 centimeter. We have already discussed this, and as you can see, within the last 4-5 years only, the same question has been repeated 3 times. Do you realize it? The way that they ask the question, and that is why PYQs become so important. I'm not saying every question will come again, but if you can see the same question from anesthesia, we've discussed it thrice. This is the 3rd time we're discussing the same question, almost the same. Okay, so here respiratory rate is wrong. This is not there. Chest compression 100 to 120 is correct. Complete chest recoil is correct, and this is correct. So 2, 3, and 4, and therefore the correct option is B. All right, chest compression 100 to 120, because respiratory rate normally we will give is 10 to 12 breaths per minute. Okay, 10 to 12 breaths per minute is what we give. All right, correct, Dr. Dheeraj. Option is B. Correct, correct. Dr. Ayush, Dr. Sainath, everyone is correct. Correct. Let's go forward. Okay, without wasting any time. Which is the most probable cause? Now you look at this question. Most probable cause of patient's hypotension and cardiac arrhythmia during modified radical neck dissection for laryngeal malignancy. When the internal jugular vein is being ligated and leading to a sudden drop in EtCO2 from 40 to 14. So if it comes in the exam, now this looks, right, if you look at this question, sympathetic overactivity, vagal stimulation, venous air embolism, carotid body stimulation. It doesn't look anywhere from anesthesia. And that's the problem. The questions from anesthesia come as very, very tricky, right? They come as tricky, but the hint is given in the EtCO2, right? There is a sudden drop in EtCO2 from 40 to 14. They mentioned that. Okay. There is a sudden drop in EtCO2 from 40 to 14. A sudden drop would mean 5 or 6 things that we discussed. Again, same repeat question. If you see, the 5-6 things that we discussed here were sudden drop would be esophageal intubation, embolism, okay, extubation accidental, disconnection from circuit, and cardiac arrest. If these points are given to me, right, just because of that embolism, right, because of the embolism will given, I will give the answer as venous air embolism, because there is a ligation of the internal jugular vein which is being there. So the vein is exposed to the air. There can be air embolism taking place, and this is what is being ligated, and there's a sudden drop in EtCO2. So therefore, air embolism is one of the things which can take place, which has led to the fall of the EtCO2, right? Apart from that, other options, sympathetic overactivity, vagal stimulation, carotid body, they according to me would not be the correct for this part, right? Because they've mentioned over here internal jugular vein is being ligated, and here there is a drop of EtCO2 from 40 to 14. So from this point of view, it falls into embolism. So answer is C. Okay. Next, which of the following, Dr. Ayush says vagal stimulation? In a way you can think of that also here, but in that case, vagus, when it gets stimulated, guys, more than straight away cardiac arrhythmias and hypotension, see, it is going to be, but then, you know, in that case, EtCO2, you can't explain EtCO2 coming down to 0, na? A vagal stimulation cannot explain this, Dr. Ayush. Okay? A vagal stimulation is not going to explain the EtCO2 decreasing. Why would a vagus stimulation? The patient is under anesthesia. A patient is under IPPV, positive pressure. In that case, why would vagal stimulation decrease the EtCO2? Did you get it, Dr. Ayush? Patient is under anesthesia. Patient is not breathing. The machine is giving the breath. So why would the EtCO2 sudden come down? The only reason that correctly falls into place is venous air embolism, and that is what led to the decrease in EtCO2, sudden drop. Convinced? Convinced? That's how questions come, guys. Okay, so this is what we have to be prepared for. When you're giving INICET, we have to use mind and try to look at the point that they've given or the pointer. ठीक है, एग्जाम में पॉइंटर आएगा ऐसा, वो कुछ ना कुछ एक छोटा सा पॉइंट देंगे, वो पॉइंट को हमको सोचना है, we'll have to think. Alright, see, that's why INICET is considered. Why don't you think it's the same thing as NEET PG entrance? Why? They've made it different because questions are asked in a different manner. They're trying to stimulate your thinking. They're trying to ask you some questions which everyone can't answer, and whether you can think it like that. Okay, so that's the point over here. Okay. Next one. Which of the following can be used as an intravenous induction agent? Lorazepam, bupivacaine, dexmedetomidine, or neostigmine? Okay. Simple question. Bupivacaine is local anesthetic. Dexmedetomidine is a alpha-2 adrenergic agonist. Neostigmine is a anticholinesterase. Okay, it is acetylcholinesterase inhibitor. Right? Are they used as intravenous induction agent? No. The correct answer is lorazepam. Lorazepam is a benzodiazepine. So yes, benzodiazepines can be used as induction agent. When you speak of intravenous induction agents. Normally we have the ones which have fast onset. Okay, and the fast onset ones are basically thiopentone, there is propofol, etomidate. One is intermediate onset and dissociative, that is ketamine. Compared to others, slightly slower onset is going to be benzodiazepine and opioids. Remember, opioids are also used in anesthesia as induction agent. Benzodiazepine and opioids, correct? So opioids are also used in anesthesia, right? So opioids and benzodiazepines are also induction agent, but relatively slower. So lorazepam is the correct answer here. Okay, Dr. Dheeraj, yes, correct. Next question. The time required for pre-oxygenation before a tracheal intubation. You're intubating someone. For how long? We've discussed this. Is it 1 minute? No. 5 minutes? No. The time for pre-oxygenation is basically 3 to 5 minutes. You can say yes sir, in that case 5 minutes is also correct. हाँ यार, वैसे तो 5 minutes भी correct है, लेकिन अगर इन दोनों में पूछोगे तो in that case the correct answer is 3. Books have mentioned 3 to 5, which means the minimum time needed, the minimum needed is 3 minutes. So out of the two options, out of the 3 and 5, I am going to choose 3. Remember, books have mentioned 3 to 5 minutes. No book says only 3. They have mentioned 3 to 5. So therefore, remember 3 and 5. 3 is also correct and 5 is also correct. But out of the two options, the correct answer that I will choose is 3 minutes. Okay, this is the time minimum needed for denitrogenation. What pre-oxygenation does is it fills up the lungs with oxygen. Okay, so it causes denitrogenation. Denitrogenation, whatever nitrogen was there, nitrogen in the lungs is replaced with oxygen. Therefore, it increases the PaO2, it increases the FRC, and because at the end of the day, because oxygen is increased, it increases the oxygenation, it prevents the hypoxia occurring and desaturation. Alright, it prevents hypoxia and desaturation. So that is the meaning of pre-oxygenation. You're keeping a mask and letting the patient breathe on his or her own for 3 to 5 minutes. It fills up the lungs with oxygen. All the nitrogen which was there in the, for example, air, it contains 21% oxygen, 70 to 78% nitrogen. The remaining 1 to 9% is carbon dioxide and moisture. All those things. Okay, air contains 21% oxygen, 70 to 78% nitrogen. The remaining 1 to 9% is carbon dioxide or other things. So this nitrogen gets replaced with oxygen, which is why it is called as denitrogenation. Okay, nitrogen gets replaced by oxygen and the lungs become full with oxygen. Okay, so that is pre-oxygenation. Done before intubation. It prevents hypoxia, it prevents desaturation. Then a patient who was on ventilator and being ventilated for the past few days suddenly pulls out the endotracheal tube. You must have seen this in the ICU. When all of you must have worked as an intern or as a post-intern, if you have gone to in your residency, if you have worked right now as a junior resident, all of you must have seen a patient who's on ventilator in the ICU being ventilated, and suddenly he was ventilated for past few days. Suddenly pulls out the endotracheal tube. What is the next step of management? Reintubate, oxygenate and reintubate, start the CPR, and watch for spontaneous and reintubate if needed. Simple. Think about what you guys have done and you will know the answer. Correct. Dr. Ansar Yadav, correct. Absolutely correct. This has been for 3-4 days. It means the patient has become a little better. He has improved. A patient has improved and he has pulled out his tube. It's possible that he's not improved, but if he has pulled out the tube, you will wait. Wait for the spontaneous breathing. Reintubate if needed. It's not that you will not reintubate, but only if needed. If the patient has improved, let it be. Instead of you, he has extubated himself. Alright, so correct. Answer D, absolutely correct. All of you have given me correct answer. Correct. Okay, next question. As an intern in the emergency ward, again a common question, and all of you have done this. Which of the following methods would you consider as correct regarding nasogastric tube length estimation? Tip of the nose to ear to Ziffy sternum, tip of the nose to angle of ear to umbilicus, mouth to the ear to umbilicus, and mouth to ear to midway between xiphisternum and umbilicus. When you do it practically, it seems very easy, but when it comes in the exam, it suddenly becomes difficult. Am I right? If I tell all of you today itself, go and put this Riles tube, all of you within 3 seconds, all of you, or 5 seconds, you'll be able to insert Riles tube, all of you. I'm pretty sure about it. But when it comes in the exam, then you start thinking yes or no. Correct. So Dr. Dheeraj, Dr. Ansa, everyone, Dr. Priya, everyone is right. Dr. Sainath, Dr. Samar, everyone is correct. Correct. But here there's a point. Correct. All of you have given me the correct answer A. You can remember it as NEX. NEX, N-E-X. Okay. Nose to ear to xiphisternum. But actually, remember the books have said it is 5 centimeter below the xiphisternum. Okay. So remember this point. 5 centimeter below the xiphisternum. So ideal point is about 5 centimeter below that. Okay. So tip of the nose, right, to the ear, and to the xiphisternum, basically 5 centimeter below the xiphisternum. That's the correct point. Okay. So that's about the nasogastric tube length. Next question. In adults, at which level does the spinal cord terminate? Okay, you can say it as an anesthesia question also, but we always discuss it as a part of spinal anesthesia. When we're discussing spinal, all of us would have always discussed whenever we discuss and we teach it. Okay, spinal cord. It starts at medulla oblongata. And where does it end? Ends at? Correct. Dr. Samar, immediate answer. Okay, L1, L2. It ends at L1, L2, and therefore you do not give spinal at L1, L2. Because it ends at L1, L2, therefore spinal anesthesia is contraindicated at L1, L2. We always give spinal below L1, L2 so that you don't damage the spinal cord. Okay, very nice. Let me change the question. Below L1, L2. Dura. If I speak of dura, where does the dura end? So guys, remember dura, it ends at S2 in adult, S4 in a child. So here also L1, L2 we have said about adult, and in a child it gets over at L3. Okay, so these are all questions which are important. Spinal cord ends at L1, L2 in adult, and in a child at L3. Dura ends at S2 in adult and S4 in a child. Next, cardiac output can be determined using the following except which one? Thermal dilution technique, capnography, esophageal Doppler, echocardiography. Yes, guys. I expect you all of you to give this answer. Okay, so cardiac output can be determined using which of the following? Thermal dilution technique, capnography, esophageal Doppler, or echocardiography. Very nice. Very nice. So Dr. Saina, Dr. Hansa, the two answers which I got. Dr. Dheeraj, Dr. Priya, Dr. Samar. Okay. Everyone has given the correct answer. Capnography. Think even if you don't know what is thermodilution, even if you don't know esophageal Doppler, even if you don't know echocardiography. See, as of now, I don't know what is this. I don't know what is this. I don't know what is this. But I know what is this. What is this? This is a graph of carbon dioxide. The only point of this capnography is to determine CO2. So therefore, CO2 and not cardiac output. So except for capnography, everything else will determine them. Okay, that's how you will cut this answer off. So many times it's possible that you get in a question where you have no answer about, you have no idea about the three options. But remember that one option you would be knowing. That one option, capnography, you know. Apart from that, maybe the other three you don't know. What is thermal dilution? What is esophageal Doppler? We don't know. Echo, we don't know. But capnography, you know. Capnography is graph of CO2 and it does not determine your cardiac output. Okay, so correct. Next. Duration of action of proparacaine. Now, this is one question which I think was not important, should not have been asked. Not needed. But since it is asked, we should discuss. Always remember, this was again one question asked in the exam, that proparacaine, this is a soluble surface local anesthesia drug. Okay, soluble surface local anesthesia drug, proparacaine. Where is it used? This is normally used in ophthalmic surgery, cataract. Okay, cataract. This is where it is used. So 2 minutes, 5 minutes, 40 minutes, cataract. 20 to 25 minutes. Normally the people who are operating fast, they finish within 25 minutes to half an hour. Just think about it, 20 minutes. So the books have mentioned the duration of action as 15 to 25 minutes for proparacaine. Right, so here the answer given was 20 minutes. So the correct answer is D. And I think Dr. Dhanush and Dr. Samad have given me correct answer. Dr. Hansa, correct. Answer is D, 20 minutes. When you speak of local anesthesia drugs in terms of classification, I can basically classify them as surface and I can classify them as injectable. The surface local anesthesia drugs can be soluble or insoluble. The soluble would include lignocaine, the gels and jelly. You will have this proparacaine, which is an opthal. Insoluble would include benzocaine, which is used in oral ulcer gel. All of you know, aphthous ulcer gel, we use benzocaine, mucaine. All right. Dr. Dhanush says D for Dhanush. Correct. D for Dhanush. Absolutely correct. यहाँ पे benzocaine हो गया. Right. Apart from that, you have oxynate and benoxynate and other drugs as well for insoluble. Injectable, guys, can be classified into 3 types. Less potent and short duration of action. Here you have drugs like procaine and chloroprocaine. Remember, procaine and chloroprocaine. Chloroprocaine, remember, is the shortest and the fastest acting local anesthesia drug. Next would be intermediate duration of action and intermediate potency. Here we have drugs like mepivacaine, cocaine, prilocaine, and lignocaine. All right. Remember, lignocaine, the maximum dose we can use is around 4 to 5 milligram per kg, and lignocaine with adrenaline, the maximum dose is 7 milligram per kg. All right, and lignocaine is the most common used. There are various concentrations available. Lignocaine comes in 0.5%, it comes in 1%, 2%, 2.5%, which comes as Emla cream, 4%, 5%, and 10%. These are the various concentrations of lignocaine, and the 2% is further divided into surface, IV, and local. All right. Remember, this local, we again 2 types: without adrenaline and with adrenaline. So these are the various concentrations of lignocaine. And the difference between IV is that this IV one has no preservative. Right? The last is long acting. Long duration of action, and these are highly potent. Here you have bupivacaine, bupivacaine. Remember, bupivacaine is the most cardiotoxic. It is the most cardiotoxic local anesthetic drug. Okay, so here we have discussed that bupivacaine, this is the longest acting. All right, and bupivacaine is the most cardiotoxic. So we discussed this part. Next, identify the device shown in the image below. Automated external desynchronizer, automated external defibrillator, automated electronic defibrillator, or automated external decompressor, AED. What does it stand for? The device is AED. B, correct. Automated external defibrillator. Correct, guys. Dr. Sama, Dr. Hansa, Dr. Dhanush, everyone is given the answer B. Okay, let's go forward. Which of the following is not a risk factor for post-operative pulmonary complication? BMI more than 30, or well-controlled asthma, upper abdominal surgery, and age more than 70. Okay, easy question, again easy one, which might look difficult, but it is not. They are asking a risk factor. They are asking a risk factor for post-operative pulmonary complication. Okay, BMI more than 30, asthma, upper abdominal surgery, and age more than 70. If you look at the first instance, everything seems to be yes, all of them are a problem. But no, if you will read it correctly, here it has been mentioned as well-controlled asthma. Why should a well-controlled asthma be a problem? So that is not a risk factor because it is well-controlled. Apart from that, BMI more than 30, yes, it's a risk factor. Upper abdominal surgery, age more than 70, yes. But if the asthma is well controlled, why it's a risk factor then? So that is the not a correct option. Okay, so I think all of you marked it correctly. Good. Next, which of the following is associated with respiratory alkalosis? Okay, so this again you need to know the modes of ventilation, not too much in detail. So here let me point out the answer. The answer here is guys, the answer here is anyone? Dr. Samar, correct. Assisted controlled mode of ventilation, or what we call as assist control mode. We call this as the assist control mode of ventilation. When you discuss the modes of ventilation, guys, remember the modes of ventilation can be classified into two types. You can classify them as controlled, or you can classify them as support. Remember, these support modes are also called as the weaning mode. Okay, so control mode can be of two types: volume control and pressure control. Volume control and pressure control. Support modes again can be of two types: SIMV and pressure support. Now, the point is, SIMV, in a controlled mode, the ventilator just gives a breath without seeing the patient's breath. Like in all the control modes, it goes like this. It just knows how to give a breath without taking care of the patient's breath. It just gives a breath. The ventilator is giving a breath. But in SIMV, what happens is the ventilator gives a breath, it waits. If the patient is breathing, it synchronizes its breath with the patient's breath. If the patient is not breathing, it gives its breath. So therefore, this is the meaning of synchronized. It is synchronizing its breath with the patient's breath. Okay. So therefore, whenever patient is breathing, it is synchronizing, which is a good thing. Then we feel, why not? Why not use this mode? Because in SIMV, it is trying to synchronize. So people made a new mode, which is a kind of SIMV mode combined with a control mode. SIMV mode combined with a control mode, and that is called as assist control mode. It's a control mode sort of combined with SIMV mode. So therefore, what happens in assist control mode, whenever patient is breathing, every breath gets supported. So therefore, what happens is, if a patient is breathing quite a lot, can you see the number of breaths that get supported becomes too much? So therefore, it increases the respiratory rate. Because of increase in the respiratory rate, it can lead to respiratory alkalosis. Okay, so therefore, that is what is seen in assist control mode. Here, control mandatory means this is control mode is what they are talking about. Okay. The second answer here, what you see, this is the control mode. This is the pressure control. And this is your SIMV. All right. So therefore, the correct answer here is A, assist control mode of ventilation. Here, the increased risk, the more patient breathes, every breath gets supported, and this is what can lead to respiratory alkalosis. All right. So that assist control mode is a problem. Next, which of the following is not a clear benefit of using high flow nasal cannula? Same, what we discussed before, HFNC, the high flow nasal cannula. What is not, which of the following is not a clear benefit. Okay. So, decreases the need of intubation, reduces nasopharyngeal dead space, heating and humidification, and PEEP. So, high flow nasal cannula. Does it reduce a nasopharyngeal dead space? It goes very fast in the nose. It displaces the air. Yes, it does reduce nasopharyngeal dead space. I had said you identify. It was the first image. You can identify it by the presence of humidifier. Does it provide PEEP? Yes, it does provide some PEEP, positive end expiratory pressure, high flow. But does it decrease the need of intubation? No, it does not decrease the need of intubation. Right? It does not. A is the answer, guys. It does not decrease. You may say, yes, it may be helpful, but it does not decrease the need of intubation per se. It's not a clear benefit. The question is, you know what? Which of the following is not a clear benefit? So is it that if you use a high flow nasal cannula, it is decreasing the need of intubation? This is not a clear benefit. Yes, it may help. I'm not denying that. But out of all the other options, decrease the need of intubation is not a clear benefit. Reduces the nasopharyngeal dead space? Yes, it does reduce. A lot of you people might be thinking, sir, B is the correct answer. But what happens? Being high flow, it displaces the oxygen. The high flow which is going inside, it does reduce the nasopharyngeal dead space which is there, especially from the nose. It's going to reduce it. Okay, it does reduce the nasopharyngeal dead space. Since it decreases with the high flow, it is decreasing the amount of oxygen present, and this oxygen is not taking part in gas exchange. That is the reason why it reduces the nasopharyngeal dead space. Clear, Dr. Ansa? All right. Okay. Doctor, somehow I did not understand your question. When acidosis हो मुझे नहीं समझा. I didn't understand your question. So बाद में we can discuss it once you are writing it down. Next question. What is the purpose of using glycopyrrolate as pre-anesthetic agent? You again saw this. It's the same question, again repeated in a different manner. What is the purpose of using glycopyrrolate as a pre-anesthetic agent? We already discussed this. Reducing the secretions, sedative effect, skeletal muscle laxant, anxiolytic. Yes, we already seen glycopyrrolate being used. Reason was to decrease the secretions, drug of choice. Okay, correct answer is A. That's how the questions come in the exam. Clear? Everyone has marked the correct answer A. Next, you are working as an intern in the ICU. Which of the following statements is incorrect about the ABG report? Okay, you have to see the incorrect one. Incorrect. Okay, we need to find the incorrect statement. That is where we have a problem. Huh? So read this. Normal pH cannot rule out acid-base disorder. You flush a syringe with 0.5 ml heparin before taking the sample. If the modified Allen test is positive, use an alternative test for sampling, and radial RT is preferred for taking the sample. Everything here seems to be absolutely correct. So what is incorrect? What is incorrect? Dr. Priya says C. Very good, Dr. Priya. Correct. It's the way the question has been said. Dr. Dheeraj also says C. Correct. Very nice. Normal pH cannot rule out acid-base disorder. Yes, it is correct. You flush a syringe with 0.5 ml heparin. Yes, all of you have done that. Yeah, all of you have done that while taking an ABG. All of you must have seen it. Radial artery is preferred. Yes, but if the modified Allen test is positive, then why will you use alternative site? You can use the same site. Remember, if the Allen test positive means it is less than 7 seconds. So if the Allen's test is positive, it is less than 7 seconds. I will use the radial site only. The point is, if the Allen's test was negative, Allen's test negative means it is more than 15 seconds. In this case, we will use an alternative site. Is it clear, everyone? If the Allen's test was negative, negative means more than 15 seconds. This is where I'm going to use the alternative site. Otherwise, I'm going to use if the test is positive, why will I use alternative site? In that case, I will be using radial artery only. So this was the catch in the question, the way they twisted it. Dr. Priya Bansal says, explain the difference between Allen modified. It's just about the radial and ulnar. In one way, you're checking for the ulnar, and one for you're checking for the radial. Okay, that's the way. All right. The way when you're compressing, what we'd seen before. It was based on that. Okay, Dr. Priya. The next one. A patient was given vecuronium and has to be reversed due to a complication. Okay, which of the following should be used? Yes, guys. A patient was given vecuronium and it has to be reversed due to a complication. So you're going to reverse the vecuronium. Which of the following is going to be used? Correct. Correct, Dr. Samar. Correct. Dr. Dheeraj. Absolutely correct. Okay. Atropine, dantrolene, neostigmine or baclofen. Remember, atropine or glycopyrrolate is not for reversal. This has been asked in the exam. Atropine and glycopyrrolate have been added or they are used in reversal to counteract the muscarinic side effects. So, when you give neostigmine to a patient, neostigmine basically blocks acetylcholinesterase enzyme. Normally what happens is acetylcholine is getting destroyed by acetylcholinesterase and it goes to the synaptic vesicles. Once you give neostigmine, it blocks acetylcholinesterase, thereby increasing acetylcholine. When the acetylcholine increases at the nicotinic receptors, it leads to the reversal of the muscle block. But at the same time, the body does not know that it has to increase only at nicotinic, right? It also increases at the muscarinic receptor. The increase of acetylcholine at the muscarinic receptor leads to the side effects: increased secretions, frothing, bronchospasm. Dumbbells, all of you know that, na? Dumbbells side effect. Okay, all the muscarinic side effects. So therefore, to counteract these muscarinic side effects, we add glycopyrrolate or atropine. It is not for reversal. That is the reason we add atropine or glycopyrrolate. Okay. Clear? Dantrolene. Remember, this is for malignant hyperthermia. Important topic. Dantrolene is for malignant hyperthermia treatment in the OT. It stops calcium release. Malignant hyperthermia, it stops calcium release because malignant hyperthermia is a disorder. So dantrolene, when you give to a patient, it stops the calcium release that is taking place and responsible for malignant hyperthermia. Baclofen is a muscle relaxant. Baclofen is a muscle relaxant. So the correct answer here is neostigmine. Clear? Next question. Alright, I think everyone has given me a correct answer, C. Alright. So RTA, a patient with RTA with GCS 8/15, the patient has tachycardia, systolic blood pressure 90, SpO2 85 with breath sounds absent on the right side on auscultation. The best management. Okay, this point has been given. Tachycardia has been given, 90, SpO2 85 with breath sounds absent on the right side on auscultation. Best management. So right side you don't have breath sounds. All right, RTA is there. So would you go in for securing airway, IV fluids, insert ICD, right? CT head and CECT abdomen, IV fluid, blood transfusion, chest X-ray, or CT head and referral. Forget everything else. Correct. All of you have given me a correct answer. Just this one point, Glasgow coma scale of a patient, less than or equal to 8. Less than or equal to 8. It means just intubate the patient. This patient can't maintain the airway. So therefore the correct answer is A, as correctly said by all of you. Forget everything else. Just that one point makes the answer A. Secure airway, IV fluids, and insert ICD, so everything falls into place. Okay. Next. Which one is correct regarding the lumbar puncture? Post-dual puncture headache is more commonly seen in females. Lumbar puncture is done at L1, L2 interspace in adult. Post-dual puncture headache is worse in lying down position, and spinal cord ends at S1 level in adult. They are not asking incorrect. Please read. They are asking you which one is correct. Okay. So many times this is the problem happens when we are appearing in the exam, which is incorrect, correct, correct, incorrect. We get confused. Which one is correct? A post-dual puncture headache more commonly seen in females. Is it true? First of all, let's see the negative ones. Lumbar puncture is done at L1, L2. Remember, spinal cord ends at L1, L2. So lumbar puncture is always done below L1, L2. So this becomes, is it the correct statement? No. Post-dual puncture headache is worse on lying down? No. It improves in the lying down position. It is worse when the patient is standing. Worse in the standing position or straining. Straining or standing, it becomes worse. Spinal cord ends at S1. We have just discussed it ends at L1, L2, L3 in a child. In adults, it's L1, L2. Not correct. So therefore, what's the answer? As all of you have said correctly, post-dual puncture headache is more commonly seen in females, especially who are pregnant. All right, females and pregnancy, and that too young. Even three factors: females, pregnant, and young. These are three factors which are responsible. Okay. Apart from that, of course, PDPH would also depend on the type of needle used. So if you're giving multiple punctures, wide bore needle, or a Dura cutting needle. Dura cutting means squinky. Dura cutting needle. So these are the factors for the post-dual puncture headache. Okay. Next, a patient on mechanical ventilation for ARDS suddenly develops tachycardia, desaturation, and absent breath sounds on one side. Chest is hyperresonant on percussion. And which of the following statements is correct regarding the condition? They have mentioned tension pneumothorax. Okay. So mechanical ventilation for ARDS, there is tachycardia, hypotension, desaturation, and absent breath sounds. You actually were supposed to diagnose it. There is hyperresonant on percussion. What will you do for tension pneumothorax? For tension pneumothorax, will you immediately do a chest X-ray before an intervention, or will you treat it? Or PEEP has been increased. If you increase the PEEP, it is going to worsen it. Okay. And non-emergency condition can be managed. So this is totally out. This is totally out. Okay. Totally out. Right. So first two options are there. Immediate chest X-ray before intervention, patient will die. So therefore, as you said correctly, all of you, the correct answer is immediate needle decompression followed by ICD insertion. Correct. Absolutely correct. All of you. Absolutely correct. Okay. Now, this question was asked last year. INICET, November. Ambu Aura 40, which we did not expect. Ambu Aura 40 is an example of supraglottic laryngeal mask airway, generation 1, generation 2, generation 3, generation 4. Remember, generation 4 is not available at all. Generation 3 is what I did not discuss with you. It's still in the infancy. People are making something called as a Baska tube. Baska tube is supposed to be supraglottic generation 3. Again, this has not come in textbooks yet, and we don't even discuss so much about it. But yes, you have supraglottic LMA generation 3 also. 1 and 2 I already discussed with you. So Ambu Aura 40, there I mentioned, if you remember, in fact, go back to that LMA. Yeah, I can't even see where it is. LMA. Where was LMA? Just give me a second. LMA. So when we are discussing LMA, if you can see, we have written first generation, classic LMA, intubating LMA, flexible LMA, unique LMA, and most Ambu LMAs. First generation. Second generation, we mentioned Proseal, Supreme, iGel, and Ambu Aura Gain. Apart from Ambu Aura Gain, everything else is a first generation. So this question that we are seeing right now regarding Ambu Aura 40. So again, some people had said it is second generation. From whatever I could find out regarding it, though they had asked, according to me, the answer is A. And this is generation 1. The only Ambu, which is Ambu LMA, that is generation 2, is Ambu Aura Gain. Ambu Aura Gain, this is generation 2. LMA generation 2. Apart from that, all Ambu LMAs are generation 1. Okay, I think everyone has marked it correctly. A. Next question. Which of the following drugs causes adrenal suppression? Thiopental, ketamine, etomidate, propofol. Easy answer. Okay. Adrenal suppression. Side effect of which one? All of you already know. Right? The reason why it's not commonly used, that induction agent, which is etomidate. Very nice, Dr. Dheeraj, etomidate. Okay, these are the problems. Normally, etomidate has 3-4 problems. One is myoclonus, nausea, vomiting, and adrenal suppression. All right. So therefore, That is with etomidate. Otherwise, remember, etomidate is the best drug. Etomidate is the best drug for a cardiac patient, right? But for serious patients, I can use opioids also. Remember this point. Huh? Opioids can also be used for a serious patient. Propofol, most of the cases, everywhere the answer is propofol. You know, whether you speak about CNS, you speak about a patient with liver disorder, renal disorder, daycare surgery, TIVA, normal sedation, ICU sedation. Okay, if you have to speak about normal intubation, LMA insertion, routine induction, everywhere the answer is propofol. Routine induction. All right, malignant hyperthermia, porphyria. Everywhere the answer is propofol. The only point is where is ketamine used. So if you get a respiratory patient with active bronchospasm, this is where I will use ketamine. And remember, if that patient, respiratory patient with no bronchospasm, I will use propofol only. All right. So respiratory patient with active bronchospasm, if I get a patient of tetralogy of Fallot, patient of this shunt, a pediatric patient, a patient in shock, this is where I prefer to use ketamine. Apart from that, out of OT anesthesia, field procedures, short procedures sometimes like burn dressings, short procedures, burn dressings, and full stomach patients, which you already discussed before, very good as antidepressant. मजा आता है, absolute मजा आता है ketamine. That is why it is used as antidepressant. All right, so the correct answer here is C, etomidate. Here I discussed with you all the drugs of choice also, which drug is used where. Okay, so that's about this question. Next, which of the following is incorrect regarding thiopentone? It is lipid soluble. It achieves maximum concentration in the brain after IV infusion. Redistribution to adipose tissue and muscle is seen, and rapid decline in its effect due to renal excretion. So incorrect. So here we have to find out the answer which is incorrect regarding thio. Okay. Is it lipid soluble? Yes. It achieves maximum concentration in the brain after IV. Correct. Yes. That's why we use it. Very fast acting. 10 to 15 seconds. 10 to 15 seconds. Right. Redistribution to adipose tissue and muscle. Yes. That is why the duration is 10 to 15 minutes. And the rapid decline effect is due to renal excretion? No. It is not due to renal excretion, but the rapid decline is because of redistribution. MCQ question. So the correct answer here is D. The rapid decline in its effect is because of redistribution to adipose tissue and muscle, which is seen with all the induction agents, right? And that is why this redistribution is the reason why all induction agents that you will see, whether it is thiopentone, whether it is propofol, whether it is etomidate, or whether it is ketamine, all of them, okay? Whether it is thiopentone, whether it is propofol, whether it is etomidate or ketamine, all of them basically have a short duration of action, basically 10 to 15 minutes. Ketamine can go a little longer, about 15 to 30 minutes, but others are 10 to 15 minutes, okay? And the reason being is that there's a rapid decline in the effect due to renal excretion. No, renal excretion nahi, redistribution. Renal excretion was the wrong answer here. Redistribution is what causes the short duration of action. Next, a female following, I'll just take 2-3 questions more, huh? Almost done. We are done, 2-3 more. A female following an RTA injured her chest. On X-ray, a fracture of the 3rd to 5th ribs was noted. Pain was not responsive to analgesic. Which block will be given to reduce the pain? Would you give a cervical block, a thoracic epidural block, supraclavicular block, or a lumbar epidural block? Okay, what will you do? So a fracture of 3rd to 5th ribs is there. Pain was not responsive to the painkiller. What will you do? Cervical block is up. Supraclavicular means Here, lumbar epidural means L1. Okay, below L1, L2, lumbar. Right. So what is left as the answer? Cervical is around C, cervical area. Supraclavicular is here, near the clavicle. Correct answer is only thoracic epidural. Okay, so this is going to work, what is going to work in the thoracic area. Right, Dr. Dheeraj, Dr. BG, right, all of you, correct answer. Okay, so thoracic epidural is the correct answer. Okay, simple, nothing here else to discuss over here. Thoracic epidural is what is used. Next, which of the following is true regarding pediatric cardiopulmonary resuscitation? Chest compression at the rate of 30:2 with 2 rescuers. With 2 rescuers in pediatric, is it there? Yes, we have discussed. If it's a pediatric patient with 2 rescuers, which of the following is true? Is it true? Is this true? We need to see which is true. A chest compression at the rate of 30:2 with 2 rescuers in a pediatric patient. Remember, in a 2 rescuer, it becomes 15:2. So this is not true. Correct? Adenosine via intraosseous route is preferred, okay, over other methods. Okay, this adenosine via the intraosseous route is preferred. I mean, would you prefer intraosseous over other methods, which would include IV? Would you prefer it? Not true. You have 2 options left. In chest compression, the depth must be at least 1/3 the chest diameter. Yes, this seems to be correct. But look at the next one. ADR is given in a dose of 0.05 mg per kg intravenous or intraosseous. Yes, it is correct. But during CPR, it is not 1:1000. We discussed it is 1:10,000. In the very beginning, we discussed this. In the very beginning. So this question has this part correct. It has 2 parts correct. 0.05. This is also correct. This is also correct. But this is wrong. And because of this reason, this is not true. So what is true is option number C, as correctly said by all of you. That the chest compression, the depth must be at least 1/3 of the child's chest AP diameter. Very good, all of you. Correct answer. Now, which of the following must be avoided in post-cardiac arrest resuscitation care? Okay, again INICT question, typical INICT question. Post-cardiac arrest resuscitation care. So this is a question that is based on the 6 links. The chain of survival. This is based on the chain of survival. This was added in 2025, modified in 2026. No, 2024 it was added, modified in 2025. Okay, there are 6 links which you see. 1, 2, 3, 4, 5, 6. Right. The 5th link here is post cardiac arrest care, and the 6th link is recovery. Both of them have been asked in exam. The 5th and 6th they have asked in the exam. Okay, so the post cardiac arrest care means what will you do after the cardiac arrest is done? All right, so which of the following must be avoided is what they're asking you. Maintain a mean arterial pressure over 65. Would you want to maintain it? Yes, I will love to maintain it. Maintains SpO2 above 94. Yes, I will want to maintain it. Revascularized position if the patient develops ST elevation. If there is ST elevation post resuscitation, will you want to do this? Yes. The cardiac CPR that we did, because of that the patient has developed ST elevation, so we will do a revascularization. But then you will read that bring down the body temperature. Yes, that is correct, but not below 32 degree. It has to be between 32 to 36, not below. This statement is wrong. Therefore, this is the answer, that this is not correct. Okay, so therefore here one of the things is that temperature has to be maintained between 32 to 36 degree. The mean arterial pressure is maintained more than 65. All right, you maintain the respiratory rate, you maintain the SpO2, put the patient on ventilator, take the patient to cardiac cath lab, and neurological consultation if needed, you know, brain dead and all. So neurological consultation is needed over here. Correct? Okay, so that is what is done. So this was based on this question, the link chain of survival. Chain on survival and chain of survival, sorry. Chain of survival, links, 6 links. All right. Jackson-Rees circuit is used in, simple, Where? Pediatric anesthesia, cardiac anesthesia, neuroanesthesia, or obstetric anesthesia. A, B, C, D. Where? So JR circuit. Jackson-Rees means JR circuit. JR circuit is used in pediatric anesthesia. Option A. Okay. Pediatric anesthesia means it is used for a pediatric patient who is less than 6 years of age, less than 20 kg. All right. That is what is Jackson-Rees. Correct, Dr. Hansa. Dr. Dheeraj. Correct. Absolutely correct. Okay. So that is what is there. Remember, for exam purposes, you just need to remember A, D, and F. 3 of them. F is what is commonly used for pediatric, right? A and D will be used in adults. So they are used in adults. Okay, both of them are used in adults. If the person is spontaneously breathing, if it's a spontaneously breathing adult, you will use Mapleson A. If there is IPPV or controlled ventilation in adult, I will use Mapleson D. Also remember, if a pediatric, this was less than 6 years of age, less than 20 kg. If there is a pediatric patient more than 6 years of age and more than 20 kg, the answer becomes Mapleson D, and that is the most common use. Okay, which is called as the Bain circuit. Mapleson A is basically the McGill circuit or the Lack circuit. Okay, Bain circuit. Mapleson A is the McGill circuit or the Lack circuit. I think all of you have given the correct answer there. Okay, guys. So there we finish off. We discussed almost 51 questions which we have taken up for the last 3-4 years, which have been there. All right. That's my Instagram ID. You have my Instagram ID. You can follow me over there. Any questions or doubts, you can also WhatsApp me. Okay, I'll share my number 9911. I'm sharing my number also with you guys. So you can share, you can ask me directly. All right. Instagram, you can follow, ask questions over there. Any questions and doubts otherwise that you have right now? Okay, so I'll feel free to ask me. Right, apart from that. So thank you everyone for joining me at this session. And I tried to finish off as fast as I could. We started at 6 and we are over before 8:30. So around 51 questions is what we discussed. Right? Any questions and doubts, guys? कुछ और पूछना चाहते हो? The best that I know. Hopefully this is helpful. The session for 2.5 hours was helpful for all of you. Any questions, doubts? Right. So I've shared my Instagram ID also. You can join me there. Okay, guys. So take care. All the best. Do well. You have my Instagram. You have my number. So if there's anything else, you can ask me. All right. All the best and do well. Bye bye. तो किसी कोई मैसेज अभी आया है तो मैं सोचा एक बार पहले देख लेता हूँ. राइट. Okay, Dr. Dheeraj, thank you. Thank you, Dr. Dheeraj. Got a message from you. Thank you so much. Okay, so no other questions perhaps, huh? Sure. Fine. So all the best to everyone, guys. Do well. And once you clear, all of you, let us know. You have my Instagram ID or my number. Let us know. Let us know how it has helped you. Right? Hopefully, a small session also must have been of some help to all of you. Okay? And any other questions, you can ask us directly. As I said before. Good night. Bye-bye.